Year-old man has been experiencing headaches for the past 2 months. On physical examination, his vital signs are temperature of 37 degrees Celsius, pulse rate of 68 per minute, respiratory rate of 15 per minute, blood pressure 130 stroke 85. He also complains of pain in the temporal area. His heart rate is regular and there are no murmurs. His erythrocyte sedimentation rate is 100 millimeters per hour. What is the most likely diagnosis? You can start from there. Anyone that would want to help with that? Thank you so much. Giant cell arteritis. So number one, that's giant cell arteritis. So this guy has got another name. It's also known as temporal arteritis. And you can see even from the question, temporal arteritis. So how did we tell that it is giant cell arteritis or the temporal arteritis? Anyone that can help with that? How did we tell? How would you tell that this patient has got giant cell arteritis and not any other condition from the given data? Okay, so when you're talking about this condition, remember it is arteritis, the inflammation of the arteries. Now, specifically, when you're talking about giant cell arteritis or temporal arteritis, it's a granulomatous, large to medium vessel vasculitis. You have got a blood. Now, we know that, say, here is our heart with the four chambers. The aorta is coming out and going down. So, the aorta is the biggest artery that we know. So, it is known as a large artery. The many branches of the aorta, those are also large branches. You have got the right subclavian, you have got the left common carotid, the left this is the brachiocephalic, and then you have got the left common carotid, and then the left subclavian. So these are big arteries. And specifically, when you look at the arc of the aorta and its branches, sometimes they can be granuloma formation of these arteries, and that is what is leading to this giant cell arteritis. And specifically for this condition, what we are picking is a common carotid artery. And you know that the common carotid is going to go and split into the internal carotid and the external carotid. Specifically, the internal carotid is going to give us one important branch that is going to supply the eye, that is the ophthalmic artery. So because in this condition we are affecting the aorta and its branches, that is telling us that all the branches that are going to come from here can all be affected. From the external carotid, we can talk about more important, that straight one, the superficial temporal, and then also the occipital. So this superficial temporal guy is the one that is going to be affected in this condition. So if you look at this, if the ophthalmic artery is the one that is affected, someone is going to end up with a condition known as ischemic optic neuropathy, because the eye will not be receiving blood, so there's going to be ischemia. The eye is optic, huh? So is ischemic optic neuropathy. And depending with any other, let's say if it is the occipital artery that is not receiving blood and that is supplying part of the brain, so there's going to be scalp infarction because it's supplying the scalp. Tissue will be dying because of no blood supply, and they can also be stroke. The temporal branch is also going to be affected, where someone is going to end up with a headache. Specifically, that headache is going to be in the temporal region. And for this condition, it is also going to be associated with fever, anemia, malaise. Someone just doesn't feel fine. Like you don't know the problem, you just don't feel fine. Weight loss, fatigue, sweat, even pain on the joints, arthralgia. So when you are making a diagnosis for this condition, there is a triad that you use. Number one, you look at if someone has got fever and then they have got anemia and then they have got an increased erythrocyte sedimentation rate. So these three things, including also being greater than 50 years and being a female. So these are the things that specifically point to giant cell arthritis. So this is basically about it. So when you diagnose someone, before you can even start making other investigations, because this is very bad, you are supposed to start treatment there and then. So you are going to be giving your patient steroid starts. They should be fast. You shouldn't delay, because if you delay, there is no blood supply. Remember, you have affected all these arteries that are supplying different parts of the body, so it can be really devastating. Okay, so those are some things that you want to tell. And so that we just finish up, when you look at a blood vessel, there is going to be inflammation of the blood vessel. Remember, this is a giant cell arteritis. There is inflammation. So if you get the patient at this condition and they died, and then you want to get a biopsy of the superficial temporal artery. Now, in this condition, what is going to happen is that there is going to be inflammation in segments. Let's say, for example, at this part there is inflammation, at this part it's normal, at this part is inflammation. So when you're getting a biopsy of the artery, you're supposed to get a bigger portion, like 3 to 5 centimeters, so that you don't end up getting just that part that is not inflamed. So for you to confirm diagnosis, you do the biopsy and you are going to be able to see giant cells. This is where you are just having white blood cells coming together, joining, and then having this multinucleated cell. You also see panarteritis, meaning that for the blood vessel, it has got intima, uh, you have got the internal, the median, and the external. So all the layers of the artery are going to be inflamed. So that will be panarteritis. And then there's going to be an increase in the lymphocytes, like the T lymphocytes, CD4 and CD8, including the macrophages. So those are some of the things that you are going to be able to see to be able to confirm diagnosis. All right, now that we've talked about everything, we can now finish up answering the question properly. So part A we've already answered. And then number two, what is the likely pathogenesis of the above condition? Anyone that can help with the pathogenesis? Anyone? What is going to cause giant cell arthritis or the temporal arthritis? Okay. So the problem in this condition is some there is a form of, it's an inflammatory condition, right? Inflammatory condition. And the problem here, the pathogenesis, there is going to be immune cell mediated inflammation. That will be the first thing. So the immune system will start attacking the blood vessels by mistake. So here is your large or your medium sized artery. Your immune system starts to attack. So I've got your immune cells attacking. Okay. So that is immune mediated inflammation. And when that happens, as the immune system mistakenly attacks the wall of these arteries, there is going to be inflammation. Because remember, part of the immune system, you have got the B cells and the T cells. So those cells are going to cause an inflammatory response. And then after that, so the first thing is there's been an immune mediated inflammation. The second thing that happens is that there's going to be formation of a granuloma. And how does that happen? The same cells that went to the site, the T cells, the B cells, these are going to start clustering together, joining together, and then they appear as just one big cell with a lot of nuclei. So a multinucleated cell, and that's what we call a giant cell. And so these giant cells are now going to start destroying or damaging the walls of the artery. First, there is the immune system starts to attack the blood vessels. That causes inflammation. Inflammatory cells start to join, and that causes the production of a giant cell. The giant cells as well start to destroy the walls of the arteries, and then later on is going to lead to what is known as vasculitis. And in vasculitis is inflammation of the vessel, which causes the wall of the artery to become thick. And when the wall of the artery becomes thick, because you're having this inflammation, look at what has happened. It becomes thick. That is making the lumen of the artery to be narrow. And so let's say this artery is supplying the brain. It means that there's going to be reduced perfusion to the brain. And you can think of all the effects, things like stroke happening. So that's the pathogenesis. Immune mediated inflammation, then later on a granulomatous formation, and then there's now inflammation of the blood vessel that causes thickening of the wall, and then narrowing of the lumen, and that causes reduction in blood flow. Is there any addition or any question before we move on? Any addition? Okay. So point one, there is immune mediated inflammation. And this is where the immune system just starts to attack the blood vessels by mistake. So the inflammation is happening because of the T cells and the B cells, okay, mediating the immune response. The second thing is there's going to be the formation of granuloma. And this granuloma is being formed because those immune cells that were attacking the blood vessel have started joining. They are clustering together. So they end up forming a giant cell. And that giant cell will start destroying the wall of the artery. And then later on, there's now going to be inflammation, vasculitis, the actual vasculitis, which is inflammation of the vessel. So the inflammation of the vessel is now going to cause the wall to start thickening. So there's going to be thickening, and besides the wall thickening, there's also going to be the lumen getting too narrow, and that reduces blood flow. Is that okay? All right. And then the third part of the question, which other vessels are likely to be affected? So here we've talked of one, even from the word. This is temporal. So the condition itself, when you are having like the temporal region, like the superficial temporal, if it is not taking blood, say this is the head, from the external carotid, you're having this superficial temporal here. If blood is not flowing enough of it to this region, that is what is going to lead to, where is that? The headache. Specifically, it is temporal headache. Okay. So anyone that can mention, we already mentioned other arteries that can be affected. Anyone? Pardon? Or the vertebral arteries. Yes, vertebral arteries can be pardon? Oh, the facial. Okay. So here we are specifically talking about specifically the large arteries. Of course, the artery will also can be affected because it's also branching from this brachiocephalic, left common carotid, and then you have got the left subclavian. So specifically, most of the problem is coming from the common carotid, internal and external. So from the external, the branches you can get specific ones, and then from the internal, of course, even these others which are branching from the arc of the aorta. There is a hand, please go on. Anyone that can mention another artery. It will even be better. Yes, please. Yes, the arc of the aorta and its branches. Since, as we said earlier, this condition is a problem of large and medium sized arteries. So the arc of the aorta itself and these its branches can be affected. So other arteries that we can mention the occipital artery, we can mention the ophthalmic artery, we can mention the vertebral arteries, the carotid arteries, basically from where this the same superficial temporal is coming from, even the arc of the aorta itself. So what you see is that if the vertebral artery is affected, there's going to be vertebral insufficient because remember the lumen is going to become smaller if the carotid arteries are the ones affected. But if we say carotid, already the superficial is coming from the carotid. So anyway, if we can just take that as a direct branch of the arc of the aorta, that is going to result to stroke because this artery supplies the brain. We can also talk about the ophthalmic that is going to the ophthalmic artery is going to result in what we are calling as the ophthalmic ischemic ophthalmic. What's the last word there? Neuropathy. Op, ha, okay, ischemic ophthalmic neuropathy. So there's that problem because you're not supplying the eye, and that is going to result in failure to be able to see clearly. Okay. You can mention some others which are coming from basically from this, but those are enough, isn't it? And we have got a lot. The subclavians are also coming from there. They can also be affected. So depending with which one is affected, you are going to have different effects. For example, when you are going down here, what is going to be the effect of reduction in blood supply to the parts going down? So those are going to be the effect, just depending with the branch that has been affected. A biopsy is performed along the affected artery in the temporal area. what histologic features will be found. So we did already mention anyone that can mention any histological feature that you are going to see. You take a biopsy. You are now trying to look at the artery. What do you expect to see if someone has got this condition? Anyone? So remember, even from the weight. Yes, thank you so much. I just wanted to mention that. So we're going to see giant cells because that's even from the name itself. Giant cells. Anything else? Yeah, the lymphocytes also, the B cells and the T cells. So there's going to be lymphocyte infiltration. Anything else? Actually, even the wall of the artery itself is going to be able to die. So it's going to undergo necrosis, and that's known as the focal necrosis. Focal necrosis is the death of the arterial wall cells. The walls of the arteries, the endothelium, will start dying. So a biopsy again, what okay, specifically here we're even looking at histological features, but if it was gross, you also see the narrowing of the arterial lumen. Besides that, there is also going to be fragmentation. Okay, like when you look at the biopsy histological, there's going to be fragmentation of the internal elastic lamina. Remember, large arteries, they've got the inside, the intima has got a part that looks like a so, like a line that looks like that. That's the internal elastic lamina. You are going to see that it's fragmented. Some parts are broken, some are just okay. So that is it for this question. Now we good? Okay. Number 6. A 40-year-old woman presents at the University Teaching Hospital Obstetrics and Gynecology Department with a history of watery vaginal discharge and postcoital bleeding. Visualization of the uterine cervix demonstrates a destructive tumor. Previous screening by cervical smear done 4 years ago demonstrated a typical squamous cell with high-grade features. High-grade squamous intraepithelial lesion (HSIL). Unfortunately, the patient never followed up her result. What is the most likely diagnosis with this current presentation? Anyone that can help? Likely diagnosis. Let's look at the things. I can point to some of them. So there is a watery vaginal discharge, postcoital bleeding. After sex, there is bleeding. And then when you look at the uterine cervix, there is a destructive tumor. Previous screening done 4 years ago, there is a typical squamous cell, high grade features. Anyone that can help, what would be the possible diagnosis? Cervical cancer. Thank you so much. Anyone that wants to add on the answer? Okay, let's do this. Here is this is the uterus. We know the end of the uterus, that's going to be the cervix. And then you are going to have the vagina here. When you look at the cervix, you have got this point, a junction, squamocolumnar junction, where the inside here, the cervix has got columnar epithelium. The outside here, the cervix has got the same epithelium of the vagina, that is simple squamous. So on this junction, this is where carcinoma of the cervix is more likely to occur. Specifically, the cervical cancer is more likely to occur here. Now, before you can have cervical cancer, there are changes. There are changes. So first, just like we talked about breast cancer, the cells will start proliferating. The cells are dividing and dividing and dividing. Okay. So when you're talking about how this condition is going to come about, so that we just integrate this information, the major predisposition factor is sexual activity. And it's not the activity itself, because after sexual activity, what is happening is that normally males, we have got this HPV virus, and it's just there. It's not causing any problem. The HPV, you have got high risk and low risk. So what happens is that after this activity, there's going to be HPV exposure. So the female genitalia is going to be exposed to the HPV virus. And what that is going to do is that it is going to cause the transition zone, this one, the squamocolumnar junction, to change. So normally before puberty, the squamocolumnar junction is inside. So this region here is known as ectocervix. This cervix which is inside here is known as endocervix. So before puberty, the the ectocervix, or let me say the squamocolumnar junction, or the cervical transition zone, is in the ectocervix. So specifically, having sex before, like early sex, before even reaching puberty for females, is a big factor that can lead them to having cancer, because, as we said, the cancer of the cervix mostly starts from the transition zone. So this sexual activity is going to cause cervical transition zone, is going to affect the transition zone. Okay, I'll put TZ. And then what is going to be the effect of that? So the effect is, remember, inside here you have got columnar epithelium, outside here you have got simple squamous. So depending with which epithelium you're affecting, if you affect the squamous epithelium, it is going to give you some problem. If you affect the endocervix, because the endocervix has got columnar epithelium, right? Endocervix. Squamous is part of the ectocervix. So you have got two possible cancers that you can have. That one which is affecting the squamous uh, epithelium is going to lead to what is known as, before you can have cancer, you're going to have the pre-malignant condition, and that is known as squamous intraepithelial neoplasm or lesion. Okay, let me put C there. So cervical intraepithelial lesion. So I'll put CIN. Hope we are okay up to here. Cervical intraepithelial neoplasm, that's CIN, is affecting the squamous cells. This one is pre-malignant, it's before having the actual cancer. And then when someone has got a cervical intraepithelial lesion or neoplasm, it is now going to lead to cervical cancer. Specifically, that cancer, because it's affecting the squamous cells, is known as invasive squamous cell carcinoma. If that was affecting the this other epithelium, the columnar epithelium, that is going to lead to the cancer that develops here, is known as invasive adenocarcinoma. Adenocarcinoma, just like we talked about the breast, remember, the adenocarcinoma is affecting the columnar cells, and then the invasive squamous cell carcinoma is affecting the squamous cell. So specifically, what type of cancer is given in this condition, in this question? They have told us that there is a typical squamous cell So this condition here is more likely to go there. Remember, like we discussed on breast cancer, when the cells are proliferating, they are going to first start cells which are typical, meaning that they are looking normal, right? And then you are going to have the atypical ones, but specifically typical, these are the ones that are looking like the cancer cells. The atypical is before then, but later on they are going to result into a cancer because that is a predisposition factor. This is okay, just a moment. Okay, sorry for that. My network just disconnected. I don't know where I ended. Have we gotten to where I talked about the invasive squamous cell carcinoma? Okay. So real quick, so what we are saying is this: someone is starting first with the cervical intraepithelial lesion or neoplasm, and that can lead to the cancer. Specifically, what type of cancer it is? The ISC. So you are having the invasive squamous cell carcinoma because it's coming from squamous cells. The one that is coming from columnar cell is going to be invasive adenocarcinoma. So specifically for this question, if you look at the data that we have been given, someone started with a high-grade squamous intraepithelial lesion. You can see there is intraepithelial lesion and squamous. So what cancer is that? Instead of us just saying cervical cancer, because we need to be specific, isn't it? So is that going to be invasive adenocarcinoma or is going to be invasive squamous cell carcinoma? Anyone? Yes, it's the invasive squamous cell carcinoma. Now this thing is important. Let me just mention before you can have the carcinoma itself, you are going to you are starting first with normal cells. So here you have your normal cells. And what is going to happen is that this, because when the cancer of the cervix is starting, it starts by affecting basal cells, like the cells at the base. The HPV will start attacking the cells at the base. So what is going to happen is that here, first, like one third of the cells at the base are going to be affected. Okay, one third of the cells at the base are going to be affected, and we call that, and that is the classification of this cervical intraepithelial neoplasm. Before you can go to the cancer, cervical intraepithelial neoplasm. So you are going to have, according to the WHO, you are going to have cervical intraepithelial neoplasm 1, cervical intraepithelial neoplasm 2, cervical intraepithelial neoplasm 3, and then you are going to go to what is known as carcinoma in situ. After the carcinoma in situ, that's when now someone is going to have the actual invasive squamous cell carcinoma. So the CIN1, cervical intraepithelial neoplasm 1, this one is where the only cells that are affected are the basal one third. And then cervical intraepithelial neoplasia type 2, Here, the lower two-thirds, so up to this point, the cells are affected. So two-thirds, lower two-thirds. So this one is referred to as a mild dysplasia because the cells are dividing uncontrollably and not properly. The sizes are not the same. They have, remember, they have got a tip. And then you are going to have the moderate, which is 2. And then you are going to have the severe dysplasia. So severe dysplasia, this is where the condition is affecting greater than two-thirds of the cervix. And then for carcinoma in situ, this is where the entire cervix is being affected. So all the cells are dysplastic, but it is not yet malignant. Okay, because it has not yet metastasized. The cells have not started yet moving. And after carcinoma in situ, that's when now you're going to have the invasive squamous cell carcinoma. So the cells are now will start now penetrating. They'll start now moving through the basement membrane, invading the tissue that is surrounding, and that is now the invasive squamous cell carcinoma. Okay, so we have talked about the pathogenesis already. If you can see, sexual activity, what does it do? It causes exposure to HPV. The HPV is now going to start multiplying, specifically high risk HPV 16, 18, 31, 33, and 35. Those are high risk. But the major one you are going to hear of is 16 and 18. But just know 16, 18, 31, 33, 35. Those are high risk HPVs. And then what will happen is that the HPV has got proteins known as, sorry, you have got these structures on the HPV, L1 and L2. These are going to help the HPV virus to attaching to the cervical epithelium. And then the HPV has got also E1 and E2. This E1 and E2 helps the HPV to start replicating. And then it has got also E6 and E7. So these two guys are going to now inhibit tumor suppressor genes. You have got P53 being inhibited by C6 and then RB being inhibited by E7. So these are tumor suppressors. They stop the division of cells when they're not supposed to divide. Now that they've been inhibited, it means that the cells will now start dividing anyhow, and that's cancer. Okay, we've talked enough. What is the cause of this tumor? Anyone? What is the cause of this tumor? So for part one, we have said this is cervical cancer, specifically invasive squamous cell carcinoma. Okay, so let's go part B. What is the cause of this tumor? We've also talked about it already. Anyone to help? Yes, please. Okay, we are going to describe it again on question C. Anyone that can help with B? What is the cause of the cancer we are talking about here? Okay, as we said, the biggest cause is high risk HPV. Which ones are those? 16, 18, 31, 33, 35. But more common, you are going to hear of 16 and 18. Those are the HPVs. And then besides that, because it's not just HPV and then you have the condition, of course there will be other problems, isn't it? So some other things that can lead to this problem is, if you can see here, unfortunately the patient never followed up the results. So this patient initially, you can see, had high grade squamous intraepithelial lesion. And they've said this was previous screening, which was done 4 years ago. They didn't have cancer yet. This was just the carcinoma in situ. It is non-malignant. But then they didn't go back. They didn't follow back their results. And so that also did contribute to them having the cancer. They have followed up? They would have been treated. They would have excision removed the benign tumor before it became this malignant. Okay, describe briefly the molecular pathogenesis of this tumor. Anyone that can answer, or maybe you can just say what I already said about the pathogenesis, or what you've read. Remember, this is molecular pathogenesis. Anyone? Doctors, are we together? Please be free to speak. Be very free. Yes, please. Thank you so much. Thank you so much for that. Any other addition to what the doctor said? Okay. Please, let's be speaking so that it will be an interesting one, huh? Because it won't be interesting if we are not speaking. Sure, sure. Thank you so much, Doc, for that. Thank you. So, let me mention this again. Cervical intraepithelial neoplasm 1, involving one third from the base of the transition zone. This is involving two thirds. This is involving this dysplasia greater than two thirds. Carcinoma in situ is the entire cervix, like the entire wall, as there's dysplasia. And then for the invasive squamous cell carcinoma of the cervix, please be specific of the cervix, because if you just say invasive squamous cell carcinoma, maybe of the breast or something else. So this one is where now there is movement. So the cells are now penetrating through the basement membrane. They are going to other parts of the body. And this first one, CIN1, this one is known as low grade. The meaning of that is that it is less likely to cause cancer later on in life. But the rest here are known as high grade. Why? Because they have got a high chance of actually resulting into the invasive squamous cell carcinoma. Okay, basically that. Again, we can describe. So on the pathogenesis, we just arrange the data that our doc has already given. Number one, pathogenesis, we are going to have initiation. After you initiate the process, number two, you are going to progress. And then after progression, number three, you are now going to have metastasis and invasion. So invasion and metastasis. So what is happening in the initiation phase is that firstly there is sexual intercourse or sexual activity. After the sexual activity, there is exposure to high risk HPV 16, 18, 31, 33, 35. Even the low risk, but they rarely cause squamous, they rarely cause cancer. It doesn't mean they can't cause cancer. And now, after there is this exposure to the high risk HPV, what is going to happen is that the HPV is going to attach to our cervical epithelium using L1 and L2. These are structural components of the HPV. So this is for adherence to the cervical epithelium. After they adhere, number two is that they'll start dividing or replicating, and they are using E1 and E2. That is for the virus starts to replicate. And then after replication, what is going to happen is that the virus has got genes, specifically known as E6. It has got these proteins E6 and E7. These are very important. E6 is going to inhibit P53. E7 is going to inhibit RB. These are tumor suppressor genes. When you inhibit them, does that cause? There is genomic instability. That is the next thing. So, genomic instability. So, this instability in the genome is going to result into genetic mutation and chromosomal alteration. Okay, and then there's going to be unnecessary division happening. And then after that, now we are going to go to the proliferation or progression of the condition. So because we have inhibited the tumor suppressor genes, what is going to happen is that the regulation of the cell cycle has been disrupted. So disruption of cell cycle regulation. Remember, you have got the G1, G2, the S phase. So those will just be happening without any control. Because after the end of the growth phases, there is a checkpoint, but those checkpoints can't do anything because the tumor suppressor genes are inhibited. And then after that, another thing that happens in progression is there is apoptosis evasion. So the cells are going to start trying to kill the other. Your immune system will be trying to kill these cells. It will not happen. So apoptosis evasion. But apoptosis is going to be different from the immune system. So there's going to be resistance of apoptosis, programmed cell death, because when the cells start uncontrollably dividing, they're supposed to be killed, but then they're going to be resisting that. Besides that, there is also going to be the evasion of the immune system, immune evasion, and this is going to result in downregulation of the immune system. The immune system is going to try all it can, but it can't do anything. And then after that, the cells are continually dividing. What continues is that there's going to be the epithelial cells are going to start changing. So as we said, the inside, the ectocervix has got squamous cell, and that is immature. So these cells, the epithelial cells, are going to start changing to mesenchymal cells, changing to mesenchyme, epithelium to mesenchymal cells. And these mesenchymal cells are going to lose cell adhesion, because remember, these cells are attached to the basement membrane and then attached to other cells. They lose adhesion. And then what happens? The cells will continue now to invade tissue. They'll continue to invade tissue. And then some of them, they are going to go into blood and the lymphatic system, and then they'll be able to spread to other regions of the body. So that is how this condition happens. So for importance, you are going to see what is known as coelocytes. These are cells that have got a prominent nucleus, because normally the base of this is the basement membrane. You have got cells on top. These are supposed to be normal cells, squamous cells. But then you are going to start, squamous cells have got uh, a, a, s- a flat nucleus. But then they're going to end up having a prominent nucleus, and they're known as poikilocytes. Are we good here? Or there's any addition? All right, thank you. Number 7, a 35-year-old male who is HIV positive presents to outpatient department with cervical lymphadenopathy. He gives a history of drenching night sweat, loss of weight, and a productive cough. A biopsy of lymph node is submitted, and histology shows foci of activated macrophages, epithelioid cells, rimmed by fibroblasts, lymphocytes, histiocytes, occasional Langerhans cells, and central necrosis with the amorphous granular debris. What is the most likely diagnosis? Anyone that can help with this one? Anyone? Let's look at what you've been given. So this patient 1, HIV positive. They have got cervical lymphadenopathy. They are experiencing night sweats, loss of weight, productive cough, and then the lymph nodes, they've got these features. Look at the features: activated macrophages, which are known as epithelioid cells, fibroblasts, lymphocytes, Langerhans cells, and then so there's necrosis on the center. Then you're having these cells surrounding the necrosis. So specifically, when you just look at cervical lymphadenopathy, someone that has got HIV, this is going to be specific, more common with, when someone has got HIV, they are more likely to get other infections caused by Mycobacterium tuberculosis. So TB is going to be the problem here. Specifically, this is known as TB lymphadenitis, the inflammation of the lymph nodes. Please, not lymphadenopathy. This is TB lymphadenitis. Now, TB, usually Mycobacterium tuberculosis, normally affects the respiratory system. But then there's also what is referred to as extrapulmonary TB. TB, that is when the Mycobacterium tuberculosis goes and starts affecting other regions of the body. Of those other regions besides the respiratory system, the most common is that the TB is going to go and affect lymph nodes, all the lymph nodes in the body. And to be specific of the lymph nodes, the most common lymph nodes affected are the cervical lymph nodes in someone that has got TB. So you're looking at cervical lymph nodes and then someone is HIV. That is enough to tell that there's TB lymphadenitis. Is that okay? Is anyone wants to add something or ask a question or anything? Anyone? Okay. And then number B is saying list at least four differentials. Anyone that can help. Where some think of any condition where someone is going to have lymphadenopathy, maybe they have got HIV, or someone has got, remember these are differentials, you can even just pick like at least the three things. Someone has got activated macrophages rimmed by fibroblasts, lymphocytes, histiocytes. Langerhans, you have the giant cells, then you have got necrosis on the center. Any condition that you can think of. Anyone? Pardon? Sarco- Thank you so much. Sarcoidosis, pneumonia. Anything else? Yeah, so even those infections affecting, remember there is lymphadenopathy. So if you think of an infection affecting the lymphatic system, like for example, non-Hodgkin's lymphoma, specifically we picked non-Hodgkin's because it is also associated with HIV. Anything else? Because we want to list at least four. Anything else? Anyone that has heard of carpal sarcoma? So carpal sarcoma is a condition is associated with HIV. It's a malignancy associated with HIV that appears with also lymphadenopathy. So at least we can mention those. Okay. The previous question, C. Oh, we didn't answer this one. What are the systemic effects of inflammation? We can simply mention them, isn't it? Anyone that can help mentioning this? So I've even mentioned some of them already. The effects of inflammation. There's going to be fever, weight loss, night sweats, fatigue, leukocytosis, anemia of chronic disease. So there's going to be anemia, hypotension, hypercoagulability. There's going to be also an increase in the erythrocyte sedimentation rate. All those things are a result of uh, what again? Of inflammation. Okay. So I'm not seeing the chat. So in case there is a question, please be free just to open the mic you speak so that I don't miss anything. Anything else before we move on? So if we go back now to D, which is saying investigations that we can do. Investigations that we can do. Since I've already mentioned, I did mention of the erythrocyte sedimentation rate and these other things. But we can as well look, as our doc said, for the investigation, the checks there, you want to look at the respiratory system, isn't it? You expect that for you to have extrapulmonary TB, you already had pulmonary. So the X-ray is going to help in evaluating the pulmonary involvement in the condition. You are as well going to look at the involvement of the cells, like the CD4 cells. Remember, this patient has got HIV, so CD4 count, and you also look at the viral load. How much virus do you have? Because that is going to help assess progression of the disease. You can as well look at tuberculin skin test. This is one important one because the tuberculin skin test confirms if someone has got TB. Remember, we said, how do you confirm if someone has got TB? You've already infected the pulmonary system. Tuberculin skin test. So what you do here is like you are injecting on the skin your microbe, and then there's going to be redness around. So that is going to say someone has got the bacteria. Okay, we are back to this question. Anyone to help with the diagnosis? Parkinson's disease. Thank you so much. Parkinson's disease. PD. List three features that are diagnostic clinically. What are you going to look at? And then you'll be able to tell that, this one has Parkinson's disease, whatsoever the matter. Number one, thank you so much. So we can basically use the trap. We have got tremor, specifically resting tremor. We have got the R there. What is going to be the R? Anyone? The rigidity. And then the A? Akinesia. Thank you so much. Or dyskinesia. Slow movement, as we've been told in the question. And then the P? The postural instability. We can see there is a stooped posture there. We can as well add the other things which are non-motor symptoms, like the same forgetfulness that we can see there, the masked faces. Which part of the brain is affected? Anyone? Thank you so much. Pars compacta, or the substantia nigra, which is part of the basal ganglia. Of course, the brainstem is also affected. We can just mention that. So don't be scared of the marks. If so I bet it will depend with how they discuss, but eh, the one who was teaching the pathology part of this one, he said if you just mention any one of those parts where there is the neuromelanin, they'll mark. You just say basal ganglia, you say substantia nigra, they'll mark. That's what he said. But just to put ourselves on a safer part, yeah. So we are good there. So substantia nigra pars compacta. If the patient happened to die and an autopsy is conducted, what changes on gross examination of this part of the brain would you see, and why? And why? And please don't be scared of marks. You can see the marks there, right? But this is something you can answer in 2 lines, but it's 10 marks. Just like this one, you just saying substantial Niagara 5 marks. So let not marks scare you. Write what you know. Okay, let's go. What are the, and this is not histological because this is on autopsy. There is gross examination. So what are you going to say on gross examination if someone has got died and then you are doing an autopsy? Is someone with Parkinson's disease? Thank you so much. Basically that. And what would you see? What's the question saying? And why? So what would you see and why? So there's going to be paleness of the substantia nigra pars compacta or the basal ganglia just. There's going to be paleness. Why? Remember what is the cause of Parkinson's disease? The major cause. Thank you so much. So basically that there is a degeneration, so there is a reduction in the dopaminergic neurons. And those neurons, we call them neuromelanin. These guys produce melanin and that gives the color for this region. So because the neurons are not there, meaning that is a reduction in the neuromelanin and so the region ends up looking pale. Another thing that you can see actually if someone has got the degeneration is that they can be also decreased brain weight because of generalized cerebral atrophy. Some source I was reading we were saying the brain can as well become atrophied. And so that atrophy is because of the reduction in the substantia nigra pars compacta volume, and that reduces the weight of the brain. Okay. What histologic feature would you see in some neurons that would help confirm your diagnosis? Anyone? The histological feature? Thank you. The Lewy bodies. Just saying Lewy bodies 5 marks. What is the histologic finding in E composed of? So what are Lewy bodies composed of? Anyone? Yeah, those things. But there is a specific one that they really want. So I remember one time when they were teaching this topic, there's a specific guy that he was looking at, such that those who mentioned other things said another one. So there should be that specific one that we can mention. So they are actually proteins which make up these Lewy bodies. Any idea? Thank you so much. Yes, alpha synuclein. So another question was actually given in class, and then they said mention two proteins. So besides the alpha synuclein, any other protein that you can find. So there's also what is known as a tau protein. So these are the proteins you'll be able to see. But more specific, what is the histologic finding? Since they just want one, just alpha synuclein is the very best you can mention. Number 9, a 22-year-old patient with diabetes mellitus comes to the accident and emergency department. She gives a 2-day history of vomiting, point that vomiting, abdominal pain, she is drowsy, and her breathing is deep and rapid. There is distinctive smell from her breath. What is the most likely diagnosis? Remember, this patient is diabetic, very vital. For me, I can make the diagnosis if I just had diabetes and the bad smell. Those are can be enough. Anyone? Thank you so much. DKA, diabetic ketoacidosis. I know it's not part of the question. Let's just make sense of it. Why do we think there is a bad smell? We can just make sense of that since it's medicine. Anyone that can help? Why is there a bad smell? Be free to respond. Anyone? Okay. So it's actually beta oxidation. It's a nice mechanism, beta oxidation. Now we know that when someone is diabetic, there is one problem here. There is too much sugar, right? And that too much sugar is going to affect really a lot of things. So what is going to be happening? Let's say here is glucose. Glucose, we know it goes into glycolysis. At the end, you form pyruvate, and then the pyruvate can be converted into acetyl CoA, and acetyl CoA can go into the citric acid cycle. Specifically, in the citric acid cycle, acetyl CoA is supposed to combine with oxaloacetate, and then they are going to form citrate. Okay, but the problem here is this: when someone has got this diabetic ketoacidosis, so the cells themselves, someone who has got diabetes, the cells have got, remember, the glucose is in blood, not the cells. Okay, and specifically, if let's say someone is fasting. So what happens, already someone has got no insulin because that is diabetes, and say someone now is fasting for that day. That fasting, even the little glucose that was present in the cells is going to be used up. And so what happens? So here, when you have got low glucose because of fasting, or maybe because of diabetes type 1, or type 1, isn't it, where you don't have the pancreas? Yes. So the problem there is that since you don't have that guy, look at what happens to acetyl CoA. What do you expect it to be? You expect the acetyl CoA to be reduced. But wait, let's say the acetyl CoA is fine. Like you have got a lot of glucose before you can have the low glucose. Let's say that is the problem. But because in our body, remember, the body is recording that we don't have enough glucose, and glucose is the major thing, source of energy for the brain, for the red blood cells, and for the kidney. So what is going to happen is that the cells don't have enough glucose. They will start taking this oxaloacetate. This oxaloacetate, in the process known as gluconeogenesis, they will start using it to make glucose. Okay, they are using it to make glucose because the body is recording that there's not enough glucose. And the problem for that is that in diabetes, you have got a lot of glucose already in blood. So you are going to have an accumulation of acetyl CoA, but this acetyl CoA doesn't have any oxaloacetate to react with. Why? Because the oxaloacetate is going to form glucose. The body is recording that there's no glucose. This glucose is present in blood. So there's going to be accumulation of this acetyl CoA. But then if the acetyl-CoA accumulates, there is a problem there. And besides that, since the body is recording that there is not enough glucose, the body is going to start using other ways to form glucose, like beta oxidation. So the body is going to be breaking down lipids. And the breakdown of those lipids are still going to be producing acetyl-CoA. We can see there is an accumulation of acetyl-CoA, but there's no oxaloacetate to react with in the citric acid cycle. So what happens is that this acetyl-CoA is going to go into the formation of ketone bodies, and that is known as ketogenesis. And those ketone bodies that you are producing, specifically you are producing the acetone. Acetone is volatile and it has got a bad smell. That is going to be responsible for the smell. Okay, so that is what happens. Oxaloacetate is deficient. Gluconeogenesis is going to cause glucose to start accumulating in blood. You also have another glucose which is already there, it's just that it's not going to the cells, so the cells falter, so there's not enough glucose. And so that is just worsening the condition. Okay, so that was a bit of the biochemistry of the ketoacidosis. Which bedside tests could you do to help you confirm this diagnosis? Anyone to help? What bedside test can we carry out to confirm the diagnosis of diabetic ketoacidosis? The random, thank you so much. So we can do the random blood sugar. Anything else? Urinalysis, thank you so much. This is bedside. Anything we should mention at least a bit more? Anything else? Any other thought? Let's say there is an accumulation of ketone bodies here. Anything that we can do to confirm that we have got high ketone bodies? Anyone? Okay. We can as well carry out blood ketone tests. And then we can do this one is C. Which laboratory tests would you request to help manage this patient? And any help there? Laboratory tests to help manage the patient? Okay. Some things we can look at is the complete blood count. We want to check. Remember, glucose itself. Glucose is good food for some bacteria and some other microorganisms. So I want to do the complete blood count to check for infections and other problems to do with blood, hematological abnormalities. Besides that, you also want to look at serum glucose, right? Serum glucose. When you look at that, you are basically monitoring blood sugar levels because you want to help in managing how bad is the condition, how bad is the blood sugar levels. And then you can as well perform some renal function tests. This is to quantify the level of the ketone, the renal function tests like blood urea nitrogen and the creatinine. You want to also look at that. because obviously the kidney is well involved in the elimination of these ketones, the ketone body. You as well want to look at the electrolytes, because if someone has got a high level of glucose, and then you're also forming these ketones, expect to have some form of electrolyte imbalance. So you want also to look at the serum electrolytes like the sodium, potassium, in case they are also not proper, so that you can as well manage that. What conditions are likely to precipitate the condition you mentioned in A? What conditions can precipitate or can make this condition to happen or to make it more likely, the diabetic ketoacidosis? Anyone? Infection. Thank you so much. Right. Thank you. MI, infections, trauma, and also omission of insulin. Imagine you take a meal that doesn't have, especially if someone knows they have got, even let's say the type, they have got diabetes, yes, and they know there is a problem there, and then they are not getting some insulin, so that also can precipitate the production of the ketone bodies because of the accumulation of the insulin. So omission of the insulin. Stress, pregnancy also. Remember, in pregnancy there is also, the pregnant women are more likely to, you are carrying someone else in the body. So just that is meaning we are going to be using up more glucose. But then the condition itself can still get to precipitate alcohol consumption. We know the alcohol is destroying the liver, and then it's the liver that is involved in a lot of conjugation reactions. And so the liver also itself, let's say someone takes alcohol, alcohol is going to cause hypoglycemia. But later on, it can cause a rebound hyperglycemia, and that precipitates diabetic ketoacidosis. Also, some drugs like beta agonists. You can do now our last question. A 34-year-old woman consulted a gynecologist 8 months after the birth of her third baby because her periods had not returned since the birth. Pregnancy had been normal, but the birth was complicated by severe postpartum. Please take note. Severe postpartum hemorrhage, for which transfusion had been necessary. The baby was bottle fed because her breast milk had been insufficient. This was in contrast to her two previous infants whom she had breastfed successfully for 9 months each. If we look at the hormones, prolactin is low, follicle-stimulating hormone is low, luteinizing hormone is low, thyroid-stimulating hormone is low, free T4 is also low, the 9 a.m. plasma cortisol is normal. So the only thing that we have here, you have got postpartum hemorrhage. The previous children were born fine, everything was okay, but this one caused a lot of bleeding after giving birth. And you can see the reduction in the hormones that are coming from the pituitary gland. So what diagnosis is indicated? Anyone that can help? Thank you so much. What has helped you to identify? Okay, thank you so much. So that is actually the main thing, because if we had a condition like hypopituitarism, we can as well have low hormones from the pituitary. But then here the problem is that the hemorrhage, the loss of blood, after giving birth is what caused the destruction of the pituitary gland. Why? There, because you have lost too much blood after birth, there is no much blood that is going to the pituitary gland, and that has affected the pituitary gland function. And so that is how someone ends up with everything coming from the pituitary gland being low. Remember, from the pituitary gland, we have got the anterior guy and the posterior guy. The posterior guy is producing ADH and oxytocin. The posterior guy is producing six hormones: adrenocorticotropic hormone, that is going to stimulate the adrenal gland to release cortisol. It's also producing prolactin, that causes milk production, producing growth hormone, also producing uh, what other hormones come from the anterior pituitary? You have got gonadotropin, stimulating hormone, gonadotropin stimulating hormone. So this guy is affecting the gonads, like the ovaries and the testes, so that they can produce your luteinizing hormone and your follicle stimulating hormone. One, two, three, four. What else have I left out or forgotten here? Any other thing that is produced from the anterior pituitary? Follicle stimulating hormone. Remember, stimulating hormones come from the pituitary. Okay, so there. Explain the psychophysiology of the disorder in A. What is the psychophysiology of this disorder? Anyone? Any idea? Be free to contribute. Is that meaning nothing? Okay, I also mentioned something already from what happened with the postpartum hemorrhage. Anyone that can connect from there? I already described it. Sure. Okay. Thank you so much. But in this case, they have asked for psychophysiology, isn't it? So what is the problem looking at? I bet we can check up in case there's any other psychophysiology besides the postpartum hemorrhage that leads to the ischemia of the pituitary gland, and that causes hypoxia to the gland. In case there's anything else, someone can find out and then be able to tell us if that is pathophysiology and not psychophysiology, because obviously psychophysiology has to do with more of the thought, and then the question of not even being told anything to do with thought. Which hormone does this patient require as a replacement therapy? Anyone? Oh, so I was adding to what the doc said. I was saying there is the low blood supply because of loss. There is postpartum hemorrhage. That means that someone has got little blood. So that little blood is going to lead to shock. So there's going to be hypovolemic shock. And that hypovolemic shock is going to, you have got little supply to the brain, because shock, remember, you have got little blood, you have got little fluid, and that because of the reduced supply to the brain, the pituitary gland, there is ischemia. Because of ischemia due to low blood supply, the pituitary gland will not be able to produce much. So they've been reduced the production of the hormones there. Right. Which hormones does this patient require as replacement? Anyone? They're like they're already here. They're already here. So we can see prolactin is low, except prolactin, there is no replacement for prolactin. But for the others, like follicle stimulating hormone, you can get to the thyroid hormones can be replaced. By the way, we replace thyroid hormones, you are going to use what is known as a levothyroxine to be able to replace them. And then you can as well replace the sex hormones. Remember, we said that you're also having the gonadotropin releasing hormone coming from here that to be able to cause the production of the sex hormones, follicle stimulating hormone and luteinizing hormone. So you can replace those. You can replace those guys. The FSH and the luteinizing hormone causes the production of estrogen and progesterone. So you will not replace the FSH and the luteinizing hormone itself, but you are going to replace the estrogen and the progesterone, which will be reduced, because that's what these guys will stimulate. These guys, when they are produced, they are going to go to the ovaries and the testes to cause the production of those. And then another thing, you can see also cortisol. You can as well do the cortisol replacement, but the thing is that cortisol here is normal, so not too necessary. But then the question would be, why is cortisol normal? If it is the hormone causing the production of cortisol is coming from the anterior pituitary. Even these others are coming from the anterior pituitary, but these others are low. Cortisol is normal. Why? Anyone that can answer that one? Anyone that can help? Okay. So when it comes to this adrenocorticotropic hormone is going to go to the adrenal gland, and it will stimulate the adrenal gland to produce cortisol. Specifically, it is the adrenal cortex. You know, in the cortex, we have got glomerulosa, fasciculata, reticularis. You are stimulating the production of cortisol. Cortisol is a stress hormone, so besides, even when you have got low of the ACTH, you can still produce cortisol. So it can still be normal even when there's no much being produced from the anterior pituitary gland, like in Sheehan's syndrome. What clinical manifestation might occur if no hormone replacement were given? Let's just look. What will be the consequence of low prolactin, low FSH, low luteinizing hormone, low thyroid hormone? Anyone? Hypothyroidism. Okay. What clinical manifestation? So, what would be the manifestation of hypothyroidism? Thank you so much. Basically, that. Remember, the thyroid hormone is involved in using up your energy, using up your energy, like in the basal metabolic rate. So if it is too much, it means that you're not going to be breaking down lipids. So you end up becoming fat. So weight gain. And because the thyroid hormone also helps in production of heat because there is increased basal metabolic rate. If it is not being used or if it is little, there's going to be cold intolerance. So besides the thyroid hormone, we also have FSH. We also have the luteinizing hormone and follicle stimulating hormone being low. What will be the effect of those? There's going to be infertility. Actually, those same-sex hormones, they also help in making strong bond. If you remember last year, there was a question that even wrote, was it in test 3? If a male, just from the childhood, the penis is removed, that male is likely, besides that, what I wanted to mention, they're likely not to grow that much, right? Because there's also an effect on growth hormone. But also, from the anterior pituitary gland, we are having the production of growth hormone. And we are also having, okay, let's not talk about growth hormone because it wasn't mentioned in the question. We are also having which one is this? We have got free T4. This guy is coming from the pituitary gland. In other words, because thyroid stimulating hormone is not stimulating the pituitary gland, it's from the pituitary gland that we also have the production of some hormones that help in regulating blood calcium. Besides that, just the hypogonadism itself cause weakness of the bone because those hormones, the gonadal hormones, also help in the strengthening of a bone. There's going to be osteoporosis. Thyroid dysfunction, besides weight gain and intolerance, it can also cause tiredness, fatigue. There's also going to be reduced libido. There's going to be reduction in sex hormone. That's the cause. What would you expect to find hyperkalemia and acidosis in this patient as it occurs in Addison's disease? Because Addison disease is also a condition where I've got low cortisol. And even in this condition, we don't have low cortisol. But then we still have the effect on the gland that helps to produce cortisol. So do you expect to find hyperkalemia and acidosis? Anyone? All right, thank you. Mhm. All right. That is on metabolic acidosis. So the doc says on acidosis. Okay, they've just said acidosis. So acidosis is not going to be, would you expect to find acidosis? No. And then, did they ask for a reason? Would you expect to find as, so they've just said, would you expect, right? So you just say yes or no. But for the sake of sake, you can just say something why you think so. So acidosis, we don't expect to find it there. The doc has said the renin angiotensin angiotensinogen system is not under the effect of the pituitary gland. But remember, the pituitary gland produces some hormones that help in electrolyte balance, like aldosterone and antidiuretic hormone. So meaning that if the pituitary gland is hypofunctional, you're expected to find those. But the only thing is that, like for metabolic acidosis, as you saw in the question, cortisol production itself is just there is only a partial reduction. It was normal. So don't expect there's no much effect on the and cortisol is a stress hormone. So if someone is stressed, what happens? You are breathing that much fast. And when you are breathing much fast, you are going to be able to be losing carbon dioxide. And when you lose carbon dioxide, you end up with metabolic alkalosis. But then it's normal, so you don't expect that much effect because there's only a partial loss or deficiency in cortisol. And then hyperkalemia also, salt regulation. As we saw, there is not much effect on the adrenal gland. Even when there is little stimulation, the adrenal gland will still produce its products. So aldosterone that helps in salt regulation is relatively preserved, and so you'll not see any hyperkalemia. So these guys are really not affected. And this is where we end for this paper.